very brain, wait.
It's midbrain.
Is the very bottom is the midbrain. What does that control? Say this with me. Everything. Blood pressure, heart rate, respiration. You can't get no more physiological Maslow's, whatever you want to call it, A, B, C, D. And it goes what? In direction of, like, if you got an injury up here, it's what? Bad. If you got an injury right here,
It's bad.
it's worse. And you got an injury right here, you're going to see the Reaper. Because this one is respiratory, cardiac, heart rate, and what else?
Temperature.
It is temperature. Your blood pressure. Guys, this is everything that keeps us alive. I've had suicide patients that just blew off the top, which is your higher level of function. They didn't affect the brainstem. It took them like 20 minutes to die. Their brainstem ain't figured out. Now, was that a mortal injury? Yes. I called a helicopter and they're like, we can't fly him. He's going to die. And that was hard. What about the meninges of the brain? Did I get it right? What's the outside one? Dura mater. Arachnoid? Where is the pia? What is it attached to, basically? The brain. Why do they call that arachnoid?
Because
It's like spider web.
It looks like a spider web. The dura mater is thick. I always try to think, and guys, from here on out, here is your disclaimer, because we got to go over burn. Where there's some graphic pictures. They are. There were scalp injury, brain matter showing. Unless your children are like mine and want to go in there and look and say that's a little aggressive, don't pull them up around your kids, especially burn. Guys, I can't teach this without showing you. And there's very graphic, renal. Dura mater, arachnoid matter, pia mater. Don't look at this. Monroe Kelly. This is the basis for ICP. What is it? 3 things that make it up. Brain, blood, CFF. If you change any of those, what happens? Somebody got to go. You got 3 roommates, and this one kicks the other one out because they taking over your room. So basically, if your ICP is going up, you have a brain tumor. Space occupying lesion, which is a brain tumor or something growing in there. When it swells, it's in the brain. Which one of those is going up? The brain is taking up more space. What's going to happen to the other 2? So if you don't get blood to the brain, what happens? Anoxic brain injury. So what does the word anoxic mean? Without oxygen. Has anybody heard this before? Oxygen don't go where the blood don't flow. What are they going to do? They're going to go into shock. They're going to go into anaerobic. All those toxins are going to be released. And what happens when the toxins are released? They swell. Sodium goes out. Potassium goes in. Water is going to follow the stuff. Right? Is everybody with me? So if I don't got no oxygen because my brain is way too big, not really, what is it going to do? Where is it going to push through? The little, guys, it's like that big. Your brain don't fit good down through there. Nothing does. By the time that herniates, I have never seen anybody come back from that. Never. You got to get it up here. Because when you get down here, we're going to talk about signs and symptoms. How can we change it? Everybody in this room can help quick. You walk in the room and the patient's posturing, and put the head of the bed up. Now, do we put it at 90? No. 30 to 45. No more than that. You can do that without a doctor's order. Why does that work? It lets gravity help you. Venous return increase. Guys, it can decrease that pressure by about 20%. I want my 20. I want my 40. No, I'm just kidding. Y'all didn't hear that. Positioning. That's our help quick, right? What about this? What meds? 3%, which is considered what? Hypertonic. So you are increasing the tonicity, the tone of everything floating around in there. What does it do? I put all the salt floating around and it pulls. It works great. When we had protocols for Lifelike, we didn't give it. Y'all think that's dangerous? That medication is highly dangerous. It always was in red writing. We would put it in 2 biohazard bags. Why do you think we did that? Because somebody has given it thinking it was normal saline. I was shocked the other day. We pulled it out at Tenova and it's in black writing. I was like, oh Lord, y'all could put that in 5 different biohazard bags. What about if you don't have 3% saline? Mannitol. Guys, mannitol is dangerous if, and this got me diving across the bed. Little Rural Hospital, they don't have 3%. They gave them mannitol. They needed it. Do you know what happens when you mix mannitol with sodium bicarb? It crystallized. And I ain't talking about honey. It hit that and it turned white and this is floating. Like I jumped across the bed, disconnected it, and just threw it on the floor. That nurse looked at me like, I'm gonna shank you in your eye. Why did you just? And I was like, no, like it's running out of the IV. They would have killed that patient so fast. I'm like, embolism maybe. Now, this is talking about your group project. Guys, y'all are way overthinking this. What are our top 3 priorities with this? What's the first one we want to do? What's it going to affect? Airway. Altered level of consciousness, right? And that puts these top 3 what's that word? What was the first day of class? Prioritization. That's Maslow's A, B, C, D, E, F, G, K, whatever. Acute versus chronic. Like this is acute. What's going to kill your patient first? If you let that altered level of consciousness go on, are they going to stop breathing? They cannot control their airway. That's priority, right? Somebody tell me what else? Huh? You got to get that blood pressure down. Maybe. Do you drop it quick?
No.
Absolutely not. Somebody give me something else that has to do with this. Is that patient a safety risk? What if it's just a little altered? What he finna do? Yeet himself on the floor, and now he got a busted head on top of his traumatic brain injury, and you're gonna be going to the CT and writing up this incident report. Safety. Guys, do you see what we just did? This is how you think. This is how I think. Every time I walk in the room, I'm looking at him, and he's like doing this, and his eyes are doing this, and I'm like, oh, that's not good. He's not responding, and then he starts posturing, and I know he was in a bath. What's going on? He's herniating. When this or this starts, it is active herniation. You too late. That don't mean we don't try. That don't mean don't go get the 3% and just do this in the room. And I know you guys are saying that, Miss Burton, that's easy. You got all. I'm not trying to tell you guys this. I'm trying to get you to what? Think through these situations. And I know when y'all did your assessments, how did they teach you to do it? The same way every time. If you just go like this every time you go in, what's going to happen? You're going to miss something. When you walk, and guys, this is what I think. I walk through the room. Oh, damn, he's got an altered level of consciousness. His GCS is 3. What am I supposed to yell out to the physician? Hey, guys, we got to intubate this patient. Did you see what I just did? Y'all gave me the top 3 priorities. And the first one you said was what? How do you fix airway? If they can't control it. Intubation. Now that doesn't mean that you're definitely going to intubate. If they can't control their airway, what can we do? Bag them and yelling down the hall, hey, 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 I need somebody to come in here and put an advanced airway. What else did we say? Safety. Don't let them, because what is the first sign and symptom of increased, this is important, of increased intracranial pressure? Altered level of consciousness. Guys, what does that mean to you? And this, do you know how many questions they put on the NCLEX about this? And I don't know why. Yes, ma'am.
I was just gonna say agitation or like form of lines, anything like that.
Exactly. Guys, if you walk in and Miss Jones say, hey baby, how you doing? How's your mom and them? And then you walk back in and she's kind of sweaty a little bit. And she's picking on stuff and you say, Miss Jones, are you okay? And she just kind of mumbles something. Is that change?
Yes.
It is. Now, because, guys, I'll be honest, until she got the other one. Wait, is it two?
It's 2
Oh, I'm sorry. I cheated y'all. Could y'all pass these around so that we can save it? Y'all can pull up your PowerPoint now. Now I want you to go to the nursing process. Does anybody know where I got that template from that I printed out that's all the color pretties? And I put a digital copy. You guys can go in and write on your iPad. I know y'all like that. I like it too. I didn't know how to do it at first, but shut up. One of the students showed me. It's hell to get old. What two things, guys? I'm not, and I can't even remember what anti-assessment. Does nursing diagnosis even matter anymore? No. I don't want ineffective gas exchange. No. What are we gonna say now? Shortness of. Why do we make it so hard? Is that the same thing? I ain't using all these book learning. Guys, you know I want to break this down so that you understand what are the two most important. I'm not going against all the things everybody says. The two most important things about the nursing process. Assessment and intervention. Which one you do first? Assess. You don't know how to intervene if you don't do assess, right? The NCLEX is written that way. They're not going to give you any nursing diagnosis. I promise. The guy that this template comes from, I told you, he is a line item writer for what? The NCLEX, and he was in on the next gen model. I went to his conference and I'm like, I want to grow up to be you. We focus on assessment. What assessments do we do for these patients? What's top three? Neuro assessment. What's involved in that? LOC? AA and O times 3 or 4. What's the fourth one? Situation. Can you tell me where you are? I'm at home. Are you at home all the time? Uh-huh. So how do we ask them the awake? You walk in and they like this. First, put their head midline. Try to wake them up. A, awake, alert, and what? Oriented. What 3 questions you ask? Know where you are. What's your name? Guys, when you go in and you ask them like this. Eric, what's your name? Eric. Is that really Eric? Nope, that's an Alzheimer's patient down the hall that came and got in Eric's bed. Eric's down in CT. What did you just do? What's your name, Eric? Don't do that. I'm serious. I hear nurses do it all the time. Mr. Jones, what's your name and birthday in April? Now, do elderly people get confused in the hospital? Don't immediately say they have an altered level of consciousness. What questions can I ask them if they're struggling? And they got their name right. They can tell you their birthday. They can't tell you the president. They don't know. They don't know what day it is. I don't know what day it is most of the time. Yes, ma'am.
Where are you?
Where are you? But what if they struggle with that and he's sitting next to me and I'm patting him on the head?
What
Do
city?
you know who that is?
Do you know who that is? Jolene? Maybe. No judgment. Okay. How about this? What color? If there ain't nobody in there, what color do I have on? Purple. I'm colorblind. Okay. If they just seem to be struggling, don't just say, oh, they NO times 1. Not really. If you go in there, hey, can you tell me what your name is? Who's the president? Whatever, they're just going to what? They're going to shut down. Slow down and ask them the questions. So we said neuro, right? What's the other thing that's in neuro assessment? G, C, S. We're going to get to that in just a second. She's back here doing this. Where's my clinical group? Y'all, were y'all in there when that stroke came in? Huh? What happened when I asked her to repeat that question? What is a FAST exam? And this is TBI too, because if they got to bleed, what do strokes? Bleeds. FAST. Facial, and can't nobody do that. It looks like a wax figure, and it's on one side or the other. And when you say smile at me, if they nah, honey, I want that smile. You walked in with the unicorns and the rainbow. Show me some teeth. So they do that, and they got facial droop. What's the A? Arm drift. Be careful with this one. If you have a 30-year-old female, and so you say, hold your hands out. She's a nurse, or I'm the nurse, and I say, Miss Nevaeh, all right, here it goes. This sounds silly. I want you to close your eyes and hold your hands out. I got my hand right here. Let that one drop. And that arm drops down. Guys, I'm going to catch it. Don't do that. What's going to happen? She is going to panic. If she is with it and she knows that just happened, she is going to panic. But what did I do? She might know that it's a little bit weak, and it might not be that, obvious. But if it comes down, then she's got a positive arm drift. And you need to say, all right, close your eyes. We're going to hold them out for 10 seconds. I'm going to call. 1, 2, and if that arm comes down, just note which one it is. And when you get done, all right, darling, you did great. These people know something is wrong. Arm drift. What's the S? Speech. Now, if somebody comes in and they're like, oh my God, they got slurred speech, and their family member comes in with them, what's the first thing you need to ask? Yes, ma'am. Who said it? Is this their baseline? She talked like that for years. I don't know. It sound like she got poop in her mouth. Y'all heard that. They sound like they were talking with a mouth full of stuff like that all the time. And you just said, oh, Lord, her speech is slurred. What's a big population up here? Military. They might have had a TBI where 10 years ago, and it affected their speech. This is not new. Now, after you found out they ain't never talked like that, y'all just said it. What do we need to know? Last time known normal. What if we don't know? We ain't seen Papa in 3 days.
Well,
3 days.
3 days.
Why do I ask them that question?
TPS, stroke.
Thrombolytics. You gonna give thrombolytics to an epidural bleed? You can if you want to. They'll bleed out of every orifice in their body. Nose, eyes, vaginal canal, rectum, and it is one of the worst things I've ever seen. You can't give it outside the window, and you can't give it if they don't meet all the criteria. If we don't know when this started, now, if I saw Eric this morning at 8 and he was fine, the ambulance brings it in at 9. When is the last known normal? 8 o'clock. If you look at them, you're on the phone, they talk to him. But what if you called them last night, it's the same thing. If they were making sense then, that's last known normal. If you called them this morning and they ain't making sense, and it was at 1 o'clock and nobody called the ambulance, because you went back to sleep, that's your last known normal. That is vital. Now EMS is probably going to ask that question, does everybody come by ambulance? No. Memo ain't acting right. What's the T? We just said it. Time, last known normal. There is one more that you might hear them do. Av who? That one is quick and dirty. What do you think the A is? Awake and alert. V? Verbal stimuli only. You walk in and they looking at you, get the hell out of my room, I don't like you, I don't like yours. Okay, you alert and awake and you talking, you got loud enough airway to yell at me. If you walk in there like this, and you say what? Mrs. Jones, get the hell out of my room, I don't like you, then what? What are they? Verbal. What's the P? Don't be a what? Butthole. Everybody take their hand and make a fist. And don't just, I want you to do a sternal rub. Does it hurt? I know we're supposed to do, guys, that's not a thing anymore. And you're going to see experienced nurses do it all the time. And you need to say, that's not evidence-based practice. How do we test a painful? Right here. And it's not this, not this. I've seen neurologists do something too, and I'm not going to do this on you, Eric, because this hurts. Let me see your hand. Girl, they take that pen and put between their fingers and press. And now y'all can do that if you want to. It freaking hurts. And I was like, I ain't never doing that. Right here. Now, under the painful stimuli, there's several criteria. What are they? If I look at you and say, quit pinching on me, you still awake and alert, you woke up. They might have just been sleeping. What if I pinch him and he reaches up with his hand and pushes my hand away? It's localized. There's enough up here. There's enough up here to say, hey, that hurts. I need to get rid of it. That's best case scenario. What if I pinch him up here and he kind of moves away? He withdraws to pain. Which one do I want? His brain is up here enough. Now he ain't awake. He ain't verbal. It's painful stimuli. I give a painful stimuli and he pushes my hand away. There's enough up here to say it is exactly there. Get off me. But this is what? My brain can't figure out where it is, kind of, so I'm just going to kind of try to get away from it. What if I pinch him and nothing happens? He is unresponsive. There are two other positions, movements that are critical in this. And this is bad. There you go. Posturing. If you have active posturing, they are herniating. What's the difference? What's the two of them? The corticate. Where's your spinal cord? Right here. Your hands come in towards the cord. What's the cerebrum? Everything is flexed out. Which one do you think's worse? The cerebrum. It's just moving down. Can you go back and forth? You can, and I had no idea that you could. I took a patient that flew out 50 feet in the car, and they're like this, and then they went like this, and I was doing that. And I was like, that is so cool. Oh my God, I need to do something.
The baby was doing that a little bit.
Oh, yeah, that's right. I did see that, yeah. We had a baby 5 months old. Now, is that kind of sus?
Very sus.
Maybe.
No, they said he had fallen off the couch a few days prior, and then they were laying on the bed with him, and he just started seizing.
Guys, we give subjective, objective information. You don't pass judgment. But you don't tell who. Oh, they fell down the stairs. And you take that child's clothes off and they have bruises from head to toe in different healing stations. You need to get your charge nurse in, and they're probably going to ring who? CPS, DHS, everybody.
He didn't have any other
No.
signs of that, but he had fallen off the couch.
Yeah,
Right.
and so if you were in, they threw them and shook him, you're not judge and jury. You were supposed to write what you see and your assessment. That's it. But now, if it's suspicious, there's nothing. Well, what if you went to your charge nurse and you're like, hey, that patient's in there season and whatever? There's nothing wrong with that. It's something wrong with it if you pass judgment. Where's Lauren? What did I do for that patient that came in with conversion disorder? And they said that they called a BFAST, they called a code stroke, and we had to take her to the CT. What did I do? I stereotyped her. Girl, she just got, and she did have borderline personality, and that's the hardest psychiatric to deal with. What did I do? I passed judgment. I was judge and jury, and I looked at you and said what? I just stereotyped her. Guys, it's not a, it is kind of a big deal that I did that. How did I fix it? I admitted it. I made a mistake. Make it right. And I'm telling all of you that as my student. Guys, you're all gonna make mistakes. I've made so many mistakes. I ain't killed nobody on thing. You're gonna make mistakes. Don't take it to heart. Find it, make a mistake, and fix it. And if somebody's yelling at you out in public, and you my student, and then you start crying, I'm gonna, And it was a student from a few semesters ago, but I was like, come here. She looked at, I don't ever try to do that. If y'all are working, I'm gonna leave you alone unless something happens. I'm still possessive. She's over there and she's upset. And I said, come here. And she didn't. And I knew that if she hurt me, what I do next? I broke into mama voice because I knew she was not going to come over there because she was upset and she was ashamed. I was like, come here. And she came over there. I said, what happened? I had heard the doctor yelled at her out in the hallway. Now, it was a septic patient, had to go to CT for something. She should have given them, she had an order for fluid. That was a little bit more important than going, how long does it take? Help quick. So she sent him over to CT, didn't have any negative effects, right? Should he have yelled at her out in the hallway? Nope. Constructive criticism where? In private. Praise where? In public. I'm going to tell everybody y'all did a good job. In front of God and everybody. Because you deserve that. You make a mistake. Own it. Find it and fix it. She learned a vital lesson that day. And the doctor, I was like, he is a butthole. He came back and apologized to her. He said, I was way out of line. I'm so sorry. Because she was like, he is never like that. And he might have been having not a Barney day. Well, what if he didn't come back and apologize? So, you fixed it, right? Yeah, it's due the 17th of November. Alright. What controls your perfusion? What's perfusion? Blood, oxygen, and carbon dioxide of the brain. Two things. Your map, which is what? It's your perfusion of what? All your tissues. Basically, how do we figure that out? You walk in there and look at it, and it gotta be. You are right. What is one blood pressure worth? Nothing. You need trends. Blue Day maps 70, and now it's 150. Now, do you know what their cerebral pressure is? You do not. But how can I figure it out? Part of it. If their map has grown exponentially, what's happening? It's going up. So this is trying to come down, and this is trying to go up. If this goes up by a huge amount, what's it going to do? Push that back up, and what are you going to have? Increased intracranial pressure. We have to control. How do we fix that? First thing, 30 degrees. That's important. Not yet. That is not in practice anymore. Hypertonic. How do I drop that blood pressure? Don't. Yes. What's cardine? It is blood pressure and heart rate. You might see nitro, and if they don't have the drugs they're supposed to use, you might see them give nitroprusside, and then when you walk in Vandy, they're going to pull it off and throw it across the room. Does anybody know what the byproduct of nitroprusside is? Cyanide. That's why he yeeted it across the room. Now, if I decrease the blood pressure, does that affect this? It's not pushing anymore. If I just slam that down, what's going to happen? Your patient's going to herniate immediately. You have to, and the physician will give you parameters, right? And they figure that out how? With each patient. You can't just slam that down. Now we want to decrease the swelling, right? What if I give them a ginormous bolus of 3% and I slam that pressure down? It's going to happen the same thing. You can't do that. What is the diagnostic that we use with this that might affect that? I ain't CBC, me drawing blood. Somebody's got meningitis. They do a spinal tap. What does that do? It puts a hole. Do I necessarily? Now you will see them do it. That's the physician's judgment. If I put a big hole and the cerebrospinal fluid starts leaking out, what did you just do? You dropped that ICP too rapidly. I've only seen them do that once, and they were in the neuro ICU. So if you do that too fast, it's on you, bro. We've already talked about this. So what does the word epidural mean? Above the dural. Subdural. Below the dura mater, right? There's one, it's not a meninges. Wait, never mind. Why is this important when they get hit and hated? What's our neuro assessment? Huh? Who said it? Y'all gotta own it. You said the right answer. Yes, pupils. If you walk in and this eye's going this way and this eye's going this way and they don't have some sort of eye problem, is that a big deal? Absolutely. What's going on? They have some sort of what? Neurological injury. And it's probably where? Right here. It's pressing on what? Your optic nerves. Yes, ma'am.
So,
sign. Yes, ma'am.
So I was at Vanderbilt, I worked there over the summer, and there was one patient there on the burn unit, and one of his pupils was bigger than the other, but he wasn't having any neurological changes at all.
That's and I can't remember the name of the diagnosis. So what's the first thing you need to ask their family in there? Do their pupils always look like
And
that?
it was new onset, like we walked in there and I went and got the nurse and they were like, what the heck, but he was fine. So I don't know.
But it's good that what? Y'all noticed it and went and asked. Worst case scenario, ain't nothing wrong. I mean, best case scenario, ain't nothing wrong. Worst case scenario, he's herniating. But you were exactly right. Does anybody know the name of that term? Starts with an I. Idiopathic. No, close. Ipsilateral. I've got this side is blown, and that is a hallmark sign that your ICP is going up. Now, if I've got weakness over here, and guys, does this really matter? If I've got weakness over here, what side of the brain is affected? This one. That is not true with the pupils for some reason. You can have, like, if you walk in and they have a certain gaze. Guys, is it important at that point? No, this is the contralateral, it's the lateral. No. It's like EKGs. I need you to know that it's not right. If you go work up in the neuro ICU, you got to figure all that out. That's not what I'm trying to teach you at this point. That is not normal. I'm doing my neuro assessment, and both of their eyes are going this way. They're not going the way they're supposed to, and the family said, they ain't never looked like that. All right, we're moving down. Breathing. What does that say? It's the relay. This is where you're going to see what? Weakness, motor problems, because the message ain't getting across, right? If you drive on down, what do you think is the first one to go down through the little hole? This one. And sometimes it's being pushed fast. You don't have very long. This is everything that keeps us alive. This is the very bottom of Maslow's, right? Every physiological process you have that keeps you breathing, your heart beating, and what else? Your blood pressure. What do I mean by that? What is the central nervous system made up of, and what's its function? You got to have an intact what? Skull, right? If you go in there and part of it's missing, is that intact? No. And you got to have what? The body has to have the ability to. We like this in every time we talk about this. You got to be in homeostasis, right? If your ICP is through the roof, are you in homeostasis? No. Why does your brain start herniating things? It's trying to save itself. It's trying to relieve the pressure, but it kind of stabs itself in the foot, right? What increases ICP? Huh? Why does body temperature increase it? It increases what? Oxygen consumption. What sets in faster? You said it earlier. Hypoxic brain injury. And then you go down that list of shock. All right, we got temperature. What else? Why does that increase that? It's putting what? If you walk in there like this, walk over there and don't just, put their head like this, and if they start seizing, you need to yell. Everything needs to be midline. If it's not, it increases the pressure. What about this? We just said this, right? This is a better thing to focus on. What effect does hypercapnia have? Huh? That, in the end, it will resort in acidosis, but this is pretty immediate. vasodilation. So if everything dilates out, what's going to happen to your ICP? It's going to go up. Back in the day, now this is not all the way gone, but the only time you would do this is when you walking in the operating room. Used to, every patient that would start herniating, what do you think we did? So if I've got hypocapnia, then my brain is going to what? Blood vessels are going to constrict, right? I want that. So what did I do with an ambu bag? I hyperventilated them. It is only like effect that long. It's not prolonged. And you can cause other problems by doing that. So you see why I'm saying we walk into the OR and they're posturing, I'm going to start hyperventilating. And then when they get in there, you got to fix what? The cause. Me hyperventilating them all day long ain't going to do a damn thing if they got a brain tumor and you don't take it out. If they're bleeding up here, you got to what? Put a hole or get the clot out. If you don't treat the cause, your patient's going to die. Now, are you immediately going to know they have a brain tumor? No. What are you going to see? Hey, their ICP's going up. I need to do all these interventions and let it to the other folks with all the letters out here. Guys, that's our job. To do that assessment, to do these interventions based on that, right? Help quick, interventions, top 3 priorities. Do you see what I'm telling you? Where else can you use that thin thinking model? On your test. How many times have I asked you, what is your first priority? What are you going to do next? If you thought through your top priorities on this, and airway is down there, hint, hint, or ventilation and intubation, what did you just do? You just figured out their top 3 priorities, and you don't even realize, y'all don't give yourself enough credit, you don't even realize you did it. Well, what if airway ain't on there, and it says, elevate the head of the bed? That's the next first thing you will do. How many questions y'all have that? Because that's what NCLEX focuses on. It all goes back to prioritization, right? You ain't ever gonna get rid. I'm gonna go work in the NICU. I don't care. The only place you wouldn't prioritize is in the morgue. You're gonna prioritize which patient you're gonna see first. Body position. Blood pressure. If that map is through the roof, you got to do something. What is this? I don't want them to. What increases that pressure? What just happened? You increase, everybody call. You increase that intra-abdominal, intrathoracic. What else increases that? Vomiting. What is a sign and symptom of hellacious increased ICP? And guys, it ain't just vomiting. This is throwing up. Have you ever? My son used to say, "Mama, I got spit in my mouth. I'm finna spit it out." Y'all, I know everybody in here is throwing up at one time and your mouth starts watering. This ain't this. You're going to walk in there like, "Whoa!" They're the Exorcist, the original one. But that increases what? I don't want them to throw up. I don't want them to have a seizure. This is just, we've already talked about this. This is 80%. 10%, 10%. It doesn't matter which one is increasing. Something is going to get pushed out. Where is our cerebrospinal fluid? It is, and it kind of surrounds the brain, got nutrients, got all the stuff. Is it just up here? Do your meninges stop right here? No. They go down and coat everything. You have cerebral spinal fluid everywhere. If you have a blockage, what's it going to increase? Cerebrospinal fluid, and now you got ICP going up. So if you figure that out, and y'all aren't going to do this, but you might get the patient ready. If they say, "Oh God, they're making too much CSF," What are they fixing to do? They're gonna put a shunt, and it runs from wherever the problem is, and it dumps in their stomach. What if they have a shunt, and now they're seizing when you walk in? What has happened? Something is blocked. That increases that pressure, because you've got what building up in the brain? Cerebrospinal fluid. Anything that affects any part of this does what to your ICP? It increases it. What if you have a bad bleed? It's going to shoot it up quick. You might not have 10 minutes. Can this be detrimental within a very short period of time? Yes. This is it. You either eat or be eaten. You're going to get thrown out the building, thrown out the house because your roommates don't like you. What is this? Not that. This. That's the same picture about 30 minutes later. What's that? That's pons, midbrain. Did I get it backwards? Huh?
Midbrain's at the top.
Yes. What's the last? We do love them both. God, do you know what that is? The foramen magnum. What is happening? They're herniating. That's ugly. What's that 5? That's how much they have herniated. Now, are you going to know that? No. You're going to know they're herniating how? You're going to walk in and they're either seizing or posturing, or they seize and then start posturing. Does anybody know why this is fuzzy? What's supposed to be right here? Your ventricles. What's missing? What do they call the little things on your brain? They're kind of squiggly. Huh? Grooves and sulci, yeah. So, what do they not have? Those. Once it's slick as glass, their ICP is so high, it has smoothed that out. We had a patient that overdosed on SSRI, and it's one of the worst overdoses I've ever seen. We finally got him stable enough to take him down from CT, and I was looking at that. I'm like, that don't look right. The neurologist walked in, said, take him back upstairs, he's going to die. And then, of course, I would. I asked him, I was like, how did you know that? And he was nice. Most neurologists are not nice, or they're strange. I guess they have to go to school so long. They're grouchy. He said, Charlotte, or he said, nurse, their brain is so swollen. Their ventricles are what? Non-existent. So much pressure, it has smoothed out everything and just shot the ventricles. You cannot come back from that. Sometimes it's not fuzzy, and you see the little squiggly lines, and you'll see one ventricle, and then you'll see the other one that's obliterated, and that one's not in the right place. What has happened? It has shifted. So have y'all ever been around and they say, oh, that patient in room 3's got a midline shift? That's what that means. Is that good? Nope. What do you think their ICP is? Through the roof. What's affected? Brain, blood, CSF. Brain, and maybe even blood, right? Here again, that answer is important. Early signs, altered LOC, headache, nausea and vomiting, what flavor? Projectile. Sleepiness, what is a flat effect? Y'all ever seen that in psych? How you doing? Fine. My leg just got cut off. There's nothing there. There's no emotion. And their family's gonna say, that's not like them. They smile all the time. Why they keep falling asleep. What is this? What makes up Cushing's?
The increased blood pressure, the low pulse, and the irregular respirations.
Bradycardia, irregular respirations, and a widening pulse pressure. What does that mean? Now, this is not a map. You come in, and her blood pressure is 120/80. She got thrown out of the car, hit her head, got a big laceration. You walk back in, and it's 200/80. What's happening? There's a widening span. Now, it might not be that obvious, but if you walk in and it's like 130/80, and then you come back in and it's 170/80, you better what? You better get somebody's attention. This is happening. So, we talked about the different areas, right? That blood pressure gonna go up, and then the heart rate goes down. What's next? Irregular respirations. What are the name of these respirations that get a lot of times? Shane Stokes. And it's breathe. It is very, guys, where are we at on the continuum of bad? We should have done something 10 minutes before 5 minutes ago. Once it starts, what is it doing? It is pressing, and it's going to affect that part. It's just the injury is just moving down. This is a point where what? Yes, ma'am.
So when you hit your head, you know, people say you're not supposed to go to sleep and stuff. Did they do that in the hospital when people were like hit injured? Did they sleep?
So, what do you think you would do in the hospital? Huh? How often at first? Like when they walk in, if they're showing serious signs and symptoms, you ain't gonna leave the room. But if they get a little bit better, what, maybe 10 minutes? 30 minutes? And then what? An hour. If they get worse, you coming back in the room. 30 minutes, 15 minutes, 30 minutes, an hour. If everything is fine, what do we go to then? 4 hours. That's how we decide what? Trends, right? You have to go in and do those neuro checks. How do you do a neuro check? Look at their pupils, ask them the questions, right? You have to do that all over again. Yes, ma'am.
I have a question. So, because my brother had a TBI, he like smacked his head really hard on concrete, but they put him in an induced coma for like 2 or 3 days to get his brain a rest. So when would they do that? Like when would they draw the line for intracranial pressure?
Does anybody know, and you can't answer this,
Oh, okay.
why do they put them in a coma?
Stimulation.
Decreases stimulation, decreases oxygen and carbon dioxide out. What does it do to your temperature? It drops your metabolism. What do we say increases it? You gonna throw up? No. What do they normally give them? This is not on the test, but I just want to see if anybody knows. They do prophylactically give them anti-seizure medications, which is usually what? Keppra. Barbiturates. And they put them in a coma. What machine do they put on their head? An EEG. I want to see what they're doing, and I want to see if they're seizing. Because if I put them in a coma, do you see the tonic-clonic? No, but you can see the electrical storm on that EEG. Lord have mercy. If it's bad enough, how quickly did they do that, Lauren?
Literally, like, as soon as he got to the hospital, I think they did 1 neuro check and they put him under.
Was his injury? I ain't trying to get any business. Was it bad?
It was bad, yeah.
It was bad. We gotta do something. So we're gonna help quick. We're gonna give him the meds. But if I can shut his brain down, that's what we need. We're treating what? Cause. I don't want the fallout for increasing his pressure. You walk in there and he's got a TBI and he's throwing up. If I just would have started that immediate. Now, if it's not that bad, are they immediately gonna put you in a coma? No. Assessment starts with an I. Intervention. Physicians do that too. Huh?
I said if you're in the military, you don't need to be scared.
Will they immediately put you out, or are you just gonna get one?
The doctor didn't want to give me one.
Yeah, the military is the same people that when they pull all your 4 wisdom teeth, they give you out of your girlfriend. Posturing, decreased motor. How might you figure that out? This goes along with a FAST exam. I'm gonna tell her what? Grab my fingers and squeeze down. This finger ain't squeezing at all. I want you to squeeze like you mad at me. This one ain't working at all. What am I gonna do next? Guys, this is this quick. What am I gonna do next? I'm gonna come, now am I gonna check her? Can you feel this? I got a sharp eye. No, I don't wanna know that. I looked at her. How quick am I fixing to do this? I walk in the room. I see her face. There's no drift. Or she's got it like this. Hey, Miss Neville, what's going on? Okay, yeah, that's not right. I need you to grip my hands, and I'm gonna come down. And I'm gonna say, all right, this is kind of silly. I want you to pull up against my hands. And she don't do nothing. Now I want you to push down like you on the gas. How long did that take? Guys, that's worth its weight in gold. Because I know now she's not moving anything. Does anybody know the question you ask to figure out speech? There's 2, I always use one. You can't teach an old dog new tricks. And it's something about I have never given it to a stroke patient. They might have had a stroke 11 years ago. I know this is silly. I need you to repeat this sentence. You can't teach an old dog new tricks. What did she do, Daryl? She slurred it. You can't. And the family's like, and they said that she has not been talking like that. I don't like the other one for some reason. The skies are always blue in Cincinnati. I like the dog. Speech. How long did that take? It doesn't. That's a huge part of your assessment, right? And you need to go in there and say, hey, this patient ain't talking right. They got a patient who's like this. Their pupils are assessment, intervention. What is it?
Your iPad has more battery.
Of course it is. Y'all taking a quick break. I gotta go get an extension cord.
Like cuts it off. I brought the veggie sandwich. And brought her lunch. Brought the veggie sandwich. You gotta get your back. Wrong part. Caesar because I need 3 or 4 of them to get the test. Gotta get really nice stuff to do. They already pass out the edibles.
Like last one I wouldn't, except for we had a little marker.
Pass the last one. There's one more to go.
Really? I'm in the bag. Yeah, like my own shit got thrown out here.